Good morning again.
I have to introduce you. I'm not going to introduce you, I haven't got my notes. You introduce yourself, I haven't got my notes.
So, I'm Paluku Bawere from Valid International. I'm going to try and share the meeting today and make sure that we keep time so that we can have enough time for discussion between the meeting during the other session. And also because I think the subject we are going to cover in this session is quite going to summarize a lot of aspects we were discussing yesterday. As you know, the session is about CMAM. CMAM development started around 1999, as I said, and it culminated with the adoption of the approach by WHO and all the UN organizations that are involved in the management of acute malnutrition in 2007. Since then, a lot has been still happening in terms of improving, in terms of addressing many of the concerns of yesterday, coverage. We need a program that has coverage. We need a program that is sustainable. We need a program that can be practical in the field. So all these aspects, I'm not going to summarize all people will present. All these aspects will be covered during the session by very, very competent speakers that was selected from the arena of all these people who started this approach and who are already involved or still involved in the approach. To capture everything the presenter will be saying and what will come from the audience, we have very, very competent and skilled rapporteur. We have Mary from ENN. I can no longer present her. She spoke yesterday a lot. She was the one teaching us yesterday. And also we have Klaus Kramer from Sight and Life, who will be with us to capture everything you will be saying so that we can get tomorrow a nice feedback of what was going on. So, second time we will directly go to the first presentation. The presentation will be by Nikki Dent from the CMAM Forum. Nikki Dent can tell you everything about CMAM because he has been at the beginning, the first cases. He was present, up to date he's still present, so he had the memory of CMAM. He is a public health nutritionist. You have the floor.
Just on both sides. Okay. Good morning. I must admit I'm very happy not to have to follow some of the very eminent, eloquent people yesterday. It's quite nice to start fresh. Also, it's very difficult to give justice to this topic in 10 minutes. As Paluku told you, it's really gone on, a lot's happened. So I'm really only able to give you a snapshot of some of the context and the challenges. Just so we all know what we're talking about, community-based management of acute malnutrition or integrated management, we have the different components of this approach: inpatient care for those children with complications, outpatient care for severe acute malnutrition without complications, when appropriate, outpatient care for moderate acute malnutrition, linking with ongoing activities, and underpinned, I have to say this, by community engagement. We don't talk about this enough. As a run-up, I've been talking to many colleagues in different contexts, from the Syria crisis to people working with pastoralists, the Nairobi slums, HIV and severe malnutrition. There's a huge amount going on. And as Paluku said, from 1999 to 2000 to today, we have some 60 countries. Forthcoming statistics will show some 67 countries adopting this approach. 2.6 million admissions with severe malnutrition, some 4.6 million with moderate, coming from UNICEF and WFP respectively. A lot's happening. We still have a long way to go when we look at these numbers. So just to set the scene a little bit, I took this table from the Global SAM Management Update that UNICEF released. It's quite a crude way of showing where countries are. But I wanted to just to use it to explain. The percentages at the top refer to the percentage of health facilities adopting, in this case, severe acute malnutrition in their services. And the point to make is that less than a quarter are really at scale, 75% to 100% of facilities. So when we talk about numbers and scale up, the majority are still at the planning, advocacy, piloting stage. And this might be due to, this is just one part of health and nutrition, also the funding issues. Again, contextually, CMAM started very much as an emergency approach, direct implementation from NGOs, and there's been a huge shift to very much Ministry of Health-led, more developmental. The word CMAM has still got emergency connotations, and we have to try and change this perspective. And I think the new WHO manual will help with this. I think over 50% of programs started CMAM in emergency context because it brings in huge resources, huge capacity, and really shoots up the profile of acute malnutrition. And I think countries are now using this to capitalize, to really raise the capacity, and often, if we can, put those resources into developmental prevention activities as well. Increasingly, I won't talk much because, and Dominique will, but there's an increasing emphasis on integration, whatever we mean by that. Yesterday we were challenged by Marco and Marie to think out of the box, and I think with CMAM we have to be flexible and innovative. We have so many different contexts. And one example that I quite like is this idea of a surge model, using resources for acute malnutrition to really try and build the health system. We know that we're dealing with some very complicated, weak health systems, and then putting in extra support when we have seasonal or emergencies coming in. Resources in terms of personnel, resources in terms of supplies, logistical support. And this is something that is being piloted in different countries. Again, I'm a bit concerned. Sometimes I didn't hear the word urban mentioned yesterday at all, and statistics are showing that over 50% of the world's population are moving to urban or peri-urban. We don't even capture those. It's low prioritization. I worked in the Nairobi slums, and I was shocked about how we couldn't get resources because people wanted surveys to show malnutrition rates is at over 10%. There aren't many surveys in slums. And if there are surveys, they often show very low levels because of the different populations. So I think we have to make this a priority. The bidonville is really a big area. And we have different issues to look at. We're going to hear about environmental enteropathy and the hygiene issues. HIV, but tuberculosis, child's tuberculosis, I think, with the crowding infection. Maybe it's access rather than availability of food. And opportunity costs. Sometimes there's not the extended family. Sometimes mothers can't take the child to work. I'm not going to get into this one, but I think Francesco clearly said it yesterday. Most of the CMAM work and pilots have been done in an African context. Most of the burden is in Asia. There are different health systems, different community networks, and I think there's some really exciting work going, but it has to be made context-specific to be able to scale up to this number. And there are questions about the appropriate product, appropriate NUAC use cutoffs. So just a couple of slides on what are we learning, what are the challenges. This is an extra one I put in because I was disappointed that Jeremy and Lola and this paper was not presented. We heard our concerns from Ministry of Health yesterday about the sustainability. And one of this is the political will, but also the stop-starts funding that's associated with these programs. And I think there's a real plea that this paper looks at, that we need costed plans, we need financing, we need consistent funding. And that links with the SUN work, which is trying to encourage countries to do costed planning. And there's many different ideas listed there, but it requires a donor vision and advocacy from us to really look at strengthening national nutrition governance. Chloe's going to adequately to cover this one, but a plea, where is the C in CMAM? It should be central. It's what made it work at the beginning, but it gets sidelined a lot. We talk about products, we talk about staff, but we forget the community is central. And there is evidence that if we invest in the community, we do get better coverage, we get better outcomes. Coverage tools are our main tool for really looking to see if we have impact in countries. And increasingly you're getting pictures like this little graph on the right, which shows that still not knowing about the services and not recognising malnutrition are top lists, top reasons for blocking people to come to services. And I think we need to do that case finding, we need to do that follow-up, we need to reduce defaulting. And there's some huge success stories. Ethiopia, health extension workers, the Women's Development Army, going down to health posts. You know, we need to learn from those successes. Again, I came to this meeting because I'm concerned. A lot of people talk about CMAM and they only really talk about severe acute malnutrition. It's kind of equated with that. And there's another group that is saying we've got to always put moderate malnutrition there all the time. And this, from this UNICEF 4-country review, is causing a lot of confusion, I think weakening. So we can't solve at this meeting, but at least if we have a direction of what are we meaning by putting these CMAM components together. This is my last slide and then my summary. People who know me will say I can't go away without putting this plea for information sharing. We're working on an initiative called the CMAM Forum to encourage cross-country sharing, to have things to do with acute malnutrition, management and prevention in one place. But increasingly, we heard yesterday from Linda and Patrick, there's a huge amount being published, workshop reports, syntheses, guidance documents, and what we're getting from the CMAM Forum is a plea from Ministry of Health and local NGOs and frontline practitioners, guide us to what's the most relevant, what is the newest, what do we do? And I think Ianette is also getting this increasing use, what do we do? There's a plea for just simplified material. There's a plea for audio-visual material. Not all cultures work with really dense documents. National protocols are getting longer and longer. And I'm not sure if you can read, yes, translation. I have to say this for my French colleagues and also not neglecting the Spanish and the Portuguese, but when we look at admission rates, I think over half of severe acute malnutrition was from the Francophone Sahel region, and yet only less than 10% of resources are available in French. The SAM guideline that came out at the end of November is still not in French. The Lancet series we talk about is still not in French. Il y a un manque de matériel en français, and increasingly in Arabic is becoming an issue. So to finish, huge advances, still big issues, quality, coverage, equity, sustainability. Where is the community engagement? Integration, what do we mean by that? Luckily my fellow speakers will talk about it. And we require a public health approach to really make it simple, give the right guidance. And can you translate in French? Like that's a plea to you. So, sorry for the non-French English speakers for speaking fast, but I just want to flash up. There's a lot going on. There's a lot to do. Thank you.
Thank you, Nikki. Thank you for giving me the 20 seconds I needed to complete my presentation of the session. So what I want to say is that we will take 3 presentations before having the first session of question and answer. And after that, we'll have 2 more presentations, and we'll end the session with another 20 minutes or 30 minutes, depending on how much time we will save of question and answer. So we will move now to the second presentation. This will be about CMAM integration, and it will be presented by, no, this is about CMAM integration, yes. Lesson learned from a case study on community-based child survival program in Bangladesh. This is by Chloe Pitt. She is also have more than 10 years of nutrition programming in different contexts Africa and South Asia. She's an epidemiologist. She likes all the aspects we were discussing yesterday, and one of her area is to see how to improve the assessment and the implementation of CMAM program. The floor is for you.
Great. Thanks, Paluku, and thanks to the conference organizers for having me present. I think he introduced my topic pretty well. I just wanted to clarify that I'm working with Action Against Hunger now, but what I'll be presenting today is from a program implemented by Save the Children US and evaluated by Tufts University. So, first a background on where the program takes place in Bangladesh. As we heard yesterday, there's a large burden of acute malnutrition in Bangladesh, and until quite recently, nutrition programs at the national level focused on behavior change, communication, and growth monitoring and promotion, whereas the undernutrition was identified via weight for age, with no mechanism to identify SAM at community level. As of 2008, when this study started, SAM treatment at the national level was mainly done through facilities, but there was no national community-based strategy. And this meant that many of these high numbers of cases of SAM were not identified nor treated. So this is where the program comes in. This was a Save the Children 5-year community-based nutrition program implemented in Borishal Division in southern Bangladesh. And this program used community health workers who were paid staff of Save the Children to implement a variety of different activities at community level, including preventive behavior change communication, along with the community case management of pneumonia and diarrhea. And in the 4th year of this program, we added severe acute malnutrition to the community health workers' workload. And this really became the CCM of SAM, or the community case management of severe acute malnutrition, because we wanted to add a new acronym to the game. And this meant that really, along with the community case management of pneumonia and diarrhea, community health workers were identifying and actually treating SAM at community level. And this was happening in one upazila. So there was a 1-year study conducted on this program by Tufts University, and it was funded by Tufts and Gain. So in terms of case identification and treatment, community health workers monitored nutrition status on a monthly basis. This happened at growth monitoring and promotion sessions and household visits. They provided counseling and sensitization on a number of topics, including items related to severe acute malnutrition, to sanitation, behavior change communication on infant and young child feeding practices. And follow-up for children who are identified as SAM happened on a weekly basis at the household level, where community health workers provided RUTF directly to the caretaker. And any cases with complications were referred to the Upazila Health Complex. The program turned out to be quite effective, with a recovery rate of nearly 92%. And I should note that the coverage of 89% is the highest of any CMAM program to date. So we measured quality of care in a number of different ways. In terms of SAM case management, a majority of community health workers, 90% of those assessed, achieved a quite high quality of care, 90% of error-free case management. We also looked at workload and found that the treatment of SAM, when added to the treatment of pneumonia and diarrhea and everything else these community health workers were doing, did add around 3 hours a week to their workload. However, we did not find that the performance on all of the other tasks that the CHWs were performing dropped. The routine, preventive, and other curative tasks, they maintained quality. And from the community side, we found that community satisfaction with the program was quite strong, and that this really led to high levels of participation among the communities. These community health workers were very familiar, trusted sources of information on child health, and their proximity enabled early presentation of cases before complications could develop. Additionally, the regular follow-up and sensitization that these workers provided on an ongoing basis really helped with the program awareness, the strong access we saw for this program, and compliance. community health workers were able to provide an effective treatment for what I demonstrated was a common illness in their communities, and a very visible one. So they received a lot of good feedback from communities, and this really helped with community health worker motivation, which is key in community health worker programs. So these community health workers, this was an NGO program. They received an adequate amount of support to promote good quality care. However, despite this support and the resources involved, we did find that the program was cost effective, both compared to other CMAM programs which used different delivery mechanisms and for which cost effectiveness data is available, and also in terms of the comparison with other child survival interventions, in terms of looking at cost per disability adjusted life year averted. This program was quite cost effective on that level as well. And finally, we saw a low cost burden to households because households did not need to purchase medicines or purchase transport to get to the health facility since care was provided at community level, and the opportunity cost of their time were quite low. There were several enabling factors in this program which really need to be discussed since when we're talking about this high quality that was achieved. This was the end of a 5-year program, and by this point the CHWs had established a strong relationship with their communities. They knew their communities and were aware of any new arrivals, so it was very difficult for an acutely malnourished child to be in these communities without the CHW being aware of them. Case finding happened on an active monthly basis, and the CHWs were receiving good support in terms of training and supervision. A key point is that the RUTF supply chain was managed by Save the Children. So there were no stockouts in this program. And as most of us are probably aware, this has everything to do with the good quality and the strong community participation and engagement in this program. Finally, the doorstep service delivery was a key component in this rural population where women had limited mobility. So we heard time and again in focus group discussions that without that component, these women probably would not have been able to bring their child for treatment until they had severe problems or complications. So there's many implications coming from this research and future directions. The one take-home message, if I could ask you to remember, is that community health workers can provide high-quality, cost-effective care for cases of severe acute malnutrition. And we would suggest a potential for adding SAM treatment to the ICCM package, or the Integrated Community Case Management Package, which UNICEF and the World Health Organization have recently endorsed, including malaria, pneumonia, and diarrhea. Because the treatment of multiple illnesses reduces the severity of SAM and makes it easier to treat. We would also like to promote that community health workers be involved in an ongoing basis in the community management of SAM. The World Health Organization has promoted that CHWs be involved in pneumonia treatment. We would like to add SAM to that list. However, we do need to assess global generalizability of these results. I'm sure you're all thinking, in your particular countries, what would this treatment look like? In our area, women's education was quite strong, 8 years on average, amongst the CHWs. And this meant that this cadre was literate and numerate. Additionally, Bangladesh is highly densely populated. So a community health worker in her rounds was able to reach a fair number of households on a daily, weekly, monthly basis. In areas with lower population density, it may take her quite a bit of time to reach all of her population, which would have implications for quality. And additionally, comorbidities which can affect the severity of SAM cases, particularly malaria in this case, were not present, were not a problem in this population. So in populations where malaria is an issue, the cases of SAM might be more complicated and more difficult to manage at community level. And finally, the main future direction is integration into the MOH system. We really need to see how this process is possible at scale. And this would have implications for coverage, participation, and quality. Finally, I did want to mention that this is a MAM conference, so we had some projections about what might happen if MAM was added to this package. And we do feel that early treatment of acute malnutrition, i.e. treating MAM by CHWs, would of course prevent many cases of SAM. And this would mean that the treatment intensity would be low and episode length would be shorter, which would make it easier to treat. We would recommend a slow start on admitting MAM cases so that you're not overwhelming the community health worker all of a sudden with large numbers of cases of MAM, which would take attention away from SAM, which we would not want to do. In general, you would need to make sure that community health workers had adequate support in terms of training and supervision. This point cannot be underscored enough because historically, community health workers have not had adequate support, and this is why we've seen so much failure in community health worker programs and them not meeting the high expectations that we have for them. We would recommend a small-scale field trial to prove this approach. However, we did want to underline that we're confident of the community health workers' importance, potential strong importance in managing SAM, but we do need to be careful about thinking about adding MAM because we don't want to overwhelm health systems, which we'll hear about next. Thanks.
Thank you, Chloe. The next presentation is by Anne-Dominique Israel. She works also with Action contre la faim, as Chloe. She has also been involved in nutrition programming for more than 10 years. She will be talking about the use of CMAM for system strengthening.
Thank you very much, Paluku. Hello, everyone. I'm very happy to be here with you today to talk about a subject that has not enough gained attention from our community so far. So a little bit of background, but I think my colleagues have already talked about this. So very quickly, the approach to management of acute malnutrition has changed a lot in recent years. But despite huge advances, we know that coverage remains shockingly low. So we estimate that around 10% only of the children suffering from severe acute malnutrition have today access to treatment. Why that? It falls now under MOH responsibility. In the early years, it was pretty much something dealt by NGOs and UNs. Now, the challenge for us as a community is to make sure acute malnutrition is truly integrated as part of a basic package of health services. So, we are now in a better position to do so because we understand better barriers to access to SAM management. In a recent publication that Chloé Pret, she worked on this publication, we understood better 5 of the most frequently reported barriers to access across intervention. The lack of knowledge on disease, the lack of knowledge on the program, high opportunity costs, Chloé talked about this and I think Nikki as well, distance to site and previous rejection. So now, how can we relate these findings to the experience of other large-scale disease experience? So in considering acute malnutrition as a disease, we can learn from existing global health program experiences. They all applied at their early stage a disease-based vertical approach. These approaches revealed great limitation. They had positive effects on the system, but they could also have very adverse effect on the system. In the mid-2000s, there was a recognition that a health system status is intrinsically related to the success and outcome of global health initiative. Weak health systems presented bottlenecks towards the same initiative meeting their objective, and conversely, global health initiative, using a vertical approach, potentially overburdened this system. So in the last year, I think our community, when promoting the integration of acute malnutrition, faced similar barriers and similar challenges. So what it tells us? We need to achieve a global shift towards horizontal or diagonal approach and be involved in health system strengthening. Most of the barriers that we're reporting in all our studies are exactly the same that other diseases are facing. I mean, there are specific barriers that we can see for some treatment, for example, the bulkiness of our UTF, for example, but the problem related to supply chain is the same for any other products or medicine. HR problems, all the problems that you can see, all the barriers that you can see in implementing any other disease-based approach. So a more global, general and coordinated effort is required to pertinently tackle those constraints and barriers. So acute malnutrition specialists need to join efforts with health specialists to achieve the reduction of the barriers identified as common. And I'm quite wondering in this room, where are these health specialists? I see, and I saw one just there from WHO, Wilson, but I'm kind of wondering, where do we have this exchange with health specialists? So we need to take a twofold approach. So simultaneously, we need to increase the availability of health services and the access. And there is this high potential for new delivery models, as Chloe explained, the ICCM model, for example. So the availability, how we reinforce this health system, how we participate to that, and the access, how we mobilize community, how we make sure, as Chloe said, and as Nikki as well, how we make sure we center our approach around communities. So our challenge is understanding how health system functions. I'm not sure we're all very specialized in that. Understanding how the basic package is delivered and how to integrate nutrition essential intervention efficiently, not only acute malnutrition management. And identifying potential impact, negative or positive, and I insist on negative, of nutrition sector's intervention on the health system globally. We have a responsibility. Now, how we could do that? Globally, we've been looking with other colleagues from other organizations, UNs, but also governments, we've been looking at how to achieve that, how to discuss with these health colleagues at district level, how to make sure we do our programs in a way that will find synergy and will reinforce the system in the longer term. So we've developed recently tools and methods to do so, and it has to start with a diagnosis of the health system. We need to know what are the weaknesses, what are the strengths as well, and we need to know how we are going to develop a multi-year strategy. So we developed a step-by-step approach to identify strengths and weaknesses of the health system and community structure. The aim is to mobilize key stakeholders on the importance of tackling acute malnutrition, of course, as a disease, and to advocate for a true implementation. I'm saying true implementation because it has to materialize within the basic package of health services. So we tested this method, and we are currently testing it in Burkina Faso, Sierra Leone, Afghanistan, and soon in other countries that are listed here. Basically, there is nothing new around this method. It's good practices. You go through a secondary data collection, primary data collection, you identify strengths and weaknesses, and then you put all the stakeholders, I say all, those who have no experience in nutrition but are involved in health, with the Minister of Health at the center of this exercise and leading this exercise, and you make sure you have a diagnosis made together at district level. And then you go to a programming phase altogether. So we had an example, and quickly, I have 3 more minutes, I will tell you a little bit about our Sierra Leone example that we just finalized last month. So there was a steering committee composition. So we have a steering committee led by the MOH at district level, but the national level was also present with the Directorate of Planning and Information. And we gathered all the partners, and we supported Ministry of Health in setting up this diagnosis by recruiting a research assistant. The role of the steering committee was to organize and put into the context the tools that we propose, standard tools, and they've developed themselves the method for the diagnosis to be done. So to give you a rough idea of what data we collected before we did this big meeting with all the stakeholders to kind of agree on strengths and weaknesses, we did observation in health center, questionnaires, individual questionnaires, but also focus group discussion. And this whole was pretty much oriented as well around the user, the community. An example of, sorry. an example of one result among a long list of results that we have, because we looked at different building blocks of the health system. You have 6 building blocks, and the supply one, I just talked about it, is a very tricky one. And we could see that there is a high frequency of shortages. And here, this example, I felt it was interesting to show, because you have here also MAM treatment that was included in the study, but as part of the whole package that is delivered at district level. So then we had the stakeholder workshop, where you ask groups of specialists implementing programs in the district to work on each of the building blocks of the health system and rate, looking at their experience, how they would talk about each building blocks. And for that, they had benchmarks to score this. Each building block so had a set of benchmarks that were reviewed per group and scored. And you end up to have a self-assessment tool. So basically the results, we cannot go too much into the details, but then you have your scoring and you see where you have your highest weakness. So the next steps, we are going to have a national meeting to talk about this diagnosis tool in May, and the programming workshop will be done in June, following up this diagnosis. So more to come soon. In short, because I have 19 seconds, we need to better understand health system as a group and focus our energy in making sure that all levels of the health pyramid are not forgotten, of course community level included. We need to join efforts again with health specialists in providing realistic options. Many people yesterday talked about this. I think Mike Golden talked about this. We need to provide realistic options, and we need to focus our energy in ensuring the access to a package, not to a single disease treatment or 2 stages of the disease. And we need to include this to reproductive health, adolescent health, and women's health, of course. Thank you very much.
Thank you, Anne Dominique, for keeping time. Then to give us the opportunity to have a number of questions. So we have 20 minutes. I was asked to inform you that we have a number of people who can speak more than 2 languages, 3 or 4. So don't be afraid to ask a question in English, French, Spanish, maybe also in Swahili, because there is a lot of people from Eastern Africa. Maybe not Swahili this time. So. Okay.
So this lady was first.
Okay. Okay. So, and then Mike, we start with you.
Thank you. I'm Esther from World Vision. I have a question to Chloe. I think we have heard a lot about arguments and debates about the use of RUTF versus the home-based food for the treatment. So in your research, do you have any insights, perhaps that you hear from the community health volunteers and from others about their perception about the use of RUTF in this case, and whether it's going to be possible to continue this? I know it's very important to build the capacity of the volunteers to do home visits and counseling, so it's very good. But in terms of making sure that they will be able to continue the program, thank you.
Can you write the question so that we get the 3, then we will respond? Yes, please.
Hi, I'm Saskia Ozendarp from the Micronutrient Initiative. I think both presentations were very, very interesting. However, they were referring to the community-based management of SAM, and we are discussing here also community-based management of MAM. And there are a couple of differences, as was already pointed out by Chloe in her presentation. Regarding the higher numbers of MAM, but also maybe the need that's more apparent with MAM to integrate it with other interventions such as IYCF education and counseling, which may result in a higher workload and burden, and also maybe higher requirements of the level of expertise of the community health workers. Now, I think the situation in Bangladesh is exceptional because the community health workers there are quite skilled and capable. That may not always be the case. I would like to get your comments upon how you see this, particularly the last speaker, how you see this applicable to the community-based management of MAM. Thank you.
Okay, Mike.
Thank you, Paluca. Mike Golden, Independent. I'm concerned about this confusion between MAM and SAM and applying the treatment of SAM to MAM and MAM to SAM. There's a number of reasons. Since the new WHO growth standards have been introduced, I've re-evaluated a lot of the children that we used to admit. And about half the children that used to be MAM have been reclassified as SAM. And many of the children that used to be classified as normal are now classified as MAM. And the MAM children are much less sick than they used to be under the old classification. The treatment is completely different. For example, the drug doses and the metabolism of drugs in a SAM child means that the drug doses have to be different from a normal child. But if you're treating a MAM child, he should be going into the IMCI and getting the same treatment as a normal child. And in Togo, for example, the staff were mixing the two of them up. We had major problems with supply because all the RUTF was being given to the MAM children, and there's 10 times as many MAM children as SAM. Suddenly, all the RUTF was consumed and we had nothing to treat the SAM children with. So the approaches from an acute emergency point of view of having SFPs and giving out supplementary food and so on have not been used in the development context for MAM. These children really have a much lower risk of death and clearly poverty associated. And things like microcredit and home gardening and hearth programs and so on really should be taking precedence over giving out a supplementary plumpy to these children, which is not sustainable at the level of children that have got MAM. And we really have to differentiate SAM and MAM quite carefully, not put them together. It's not just a question of overburdening the health system. That is a problem, but it's also a question of having different treatments at a clinical level between the MAM child and the SAM child. So, and if you have the same product being used for them both, they must be clearly distinguished with different labeling, different names, different packaging. Otherwise, the RUTF, which is meant as a therapeutic drug to treat an acute illness of the SAM child, is going to just be dissipated on treating relatively low-risk children and stunted children for MAM. So I agree wholeheartedly with what was said in the last question. That these presentations have been about SAM, and they should not be applied to MAM. We should have different programs for MAM.
Okay, okay, right. Because that was a comment, we'll get one more question.
Thank you. My name is Imrad Jordan from the University of Gießen. I was very happy that you mentioned actually the point adequate support and training and supervision of those health workers. And I would like to know a little bit more about what would you recommend in the area of Bangladesh, considering that they have already quite high school education, and if you reduce that level and transfer, put it into another context with much lower education, what kind of training supervision we need then to actually make programs like this successful? Thank you.
Can I respond? I think Chloe will start, then Dominique will...
Okay, on the point about the continuation of the program and is it sustainable, I think, this is clearly a key question. This was a pilot study. I think it was to prove a kind of proof of concept that I think the main takeaway is that this level of worker can manage cases of SAM according to simplified treatment algorithms. But the whole question of delivering product through, especially through local health systems, is really key. And I'm afraid I don't have the answer. I know there was local production happening in Bangladesh at some point. Maybe some audience members can chime in if what the status of that is, which would make things easier. But again, through local health systems, not having Save the Children with their logistics capacity delivering, very, very key question really, and really to see in the next stages how we're able to manage that. The question around the training and supervision of community health workers. I know that there is, in this particular program, we had a 3-day intensive training at the beginning with a large practical component that worked quite well, and regular refresher trainings. There is work that I've heard of recently in South Sudan, with a much lower education level, where really some innovative work is being done on what tools to use, where literacy is not there. And I think in these settings, even more so than in literate settings, you do need to be sure that supervision is very strong. We often see, even in the Bangladesh program, we had a higher number of community health workers per supervisor than is recommended. If you're in a setting with low literacy, you need 10 to 20 community health workers per supervisor tops, so that these supervisors can provide good supervision, especially at the beginning of the program. We saw at the beginning of the program that they needed more support than later on as they're learning the system. So I think that there's simplified tools being developed, but still tons of work to be done in this area.
First, I would like to thank you, Mike and Saskia, for your question. I was expecting to have this conversation after the presentation. You pretty much touching a point that in Action Against Hunger we are quite worried about and looking at. My presentation was especially around SAM, it's true, and around health system strengthening. And we need to raise the question that Nikki raised. Is it sustainable? Is it possible for a health system to absorb supplementary feeding program, the way we implemented it in big emergencies? We don't believe it's really possible. Your point about IMCI is very relevant, and I have to say that we have in Chad, for example, this pilot that we are running, where we decided not to implement food-based approach for MAM children, but a more soft approach with medical consultation for their basic illnesses and counseling. We do think, when we talk about health system strengthening, that SAM management and MAM management are two different issues, and we do think that we need to find different ways in doing MAM, not excluding MAM children, but making sure that they have true access to the health system. Dealing with basic diseases, making sure they have access to growth monitoring, for example, when we do our health system strengthening, are key essential actions that we want to make available while we strengthen the system. So I couldn't agree more with you, and this is pretty much the way we want to work.
Thank you. 3 more questions. Yes. Josephine?
Yeah, just a follow-up on the question Mike raised or the comments he made. I also observed, I think this comment is basically for Nikki, that when you made a presentation in terms of the coverage and the numbers we are reaching, it's a combination of both SAM cases and MAM. And I really want to again emphasize, like the other colleagues, that we have over the years managed to maybe convince a number of governments in terms of the importance of treating MAM as, making sure there is SAM, making access to each and every child who is severely malnourished having access to treatment. And I think even so, it's obvious that in a number of countries, governments are struggling because the numbers are so huge. And I really think expanding that concern to MAM would even complicate issues more, because financially they wouldn't be able to manage. So I think we really have to be clear that in non-emergency situation, the focus in terms of treatment, ensuring available treatment, should be to some cases where we have over the years established the linkage between mortality risk attached to some cases. Then in terms of the MAM management, it really has to be linked to the preventive. We need to sell it in the the context of the packages which have been proven to be, effective, and that's what we should promote. And then I also was expecting coming here that in emergency contexts where we both implement some management and also MAM and preventive, there are a lot of concerns regarding products, regarding the quality and so on. How do we ensure that we at least provide a bare minimum in terms of packaging the intervention for prevention in emergencies, as well as the focus on products? So I really think we need to be clear, otherwise, we keep going back and forth, and we could easily confuse governments, and we have colleagues here who are like wondering, okay, what do I go back with? What is the take-home message for me? And now in a non-emergency situation, for example. And I really think we need to be clear. Thank you.
Just a quick comment about that issue about should we be concerned about MAM children or not. Maybe let us address that question after the last presentation of this morning, when McManry will address a bit that question. So let's move to the question of Roxanne.
Thank you very much, and Chloe, thank you for your presentation. Following on from what Josephine says, those are my concerns as well. I mean, I didn't hear the preventive aspect at all in your presentation. And fortunately or unfortunately, I have been in the field, in the SAVE area, and have watched the community health workers when they were talking to mothers and giving the product. So all they did was give the product. There was absolutely no counseling on breastfeeding. There was no counseling whatsoever on any other complementary food that the child should have been given. So what happens as a result? And this is something that I asked, and I got the answer later on, that sure, they do very well, they regain their weight, they get discharged, but then they fall back. And why do they fall back? Because the health worker did not tell them what to do in addition during that time period, and to prepare them for the time when the RUTF would finish. So that component is something that I would really like to hear from you, and I think it's extremely important. And again, this is very worrying. MAM, I've seen MAM, I always thought should be focusing more on the preventive aspects, but if we are talking about just giving products, then it's going to be extremely difficult and very, very worrying. Thank you.
Isaka, introduce yourself.
Isaka Job, Helen Keller International Regional Office. The previous person addressed my question regarding the link between prevention and treatment, but I want to make a follow-up question for Chloe regarding the high coverage rate I found in that pilot, and wonder whether any follow-up assessment was conducted to see how it is evolved. Thank you.
Okay. Tamin.
Thank you. First of all, I would like to thank Mike for the excellent comment. MAM, SAM are totally different. Stunting is also different. The fear that I have yesterday and today, that we are perhaps, going towards days where we will have a single product that we will use for the treatment of all these things, which will be extremely dangerous. So thank you very much. There was a question whether the Barisal experiment on treating SAM, is it sustainable in Bangladesh or not? Being a Bangladeshi, let me tell you my views. This, as Chloe has rightly pointed out, is a proof of principle. But to tell you the truth, the way it is being done is not going to be sustainable. Had it been sustainable, then the governments in South Asia, including that of my country, Bangladesh, India, Nepal, they would all have embraced this thing long ago, and we wouldn't have this huge burden of SAM and MAM, much larger than what it is in Africa. The question is, who pays for it? Look at the meager budgets in the ministries of health in all these countries, and look at the cost at which we require to treat one single episode of SAM, $165. When I go and talk with my government, the secretary, they say, come on, forget it. We have so many other competing things to deal with. So what is the solution there? Are we all pessimists? No. Bangladesh has done tremendously well. And I can tell you today that working with the government of Bangladesh, we have been able to develop local RUTF made of locally available food ingredients. We are going through the efficacy, the effectiveness trials, much the way that Rebecca Grace yesterday talked about. And after all this local evidence, we are hopeful that we will be having a sustainable, cost-effective approach to treating SAM. On the other hand, MAM, I totally agree with what has been said. You need to combine this with preventive approaches, with water, sanitation, hygiene, environmental enteropathy, creating livelihoods, improving existing livelihoods. If you don't do that, these programs will never work. And that's what we aim for in Bangladesh. Thank you.
I was not directly pointed, but I would like to respond to you, Tahmid. I think what you're pointing out on SAM management is a key question for all diseases. Do the government of each country have the capacity to implement a treatment, whatever it is? Of course, and everybody will agree, local production is the way to go. But now, when we are talking about SAM or malaria or HIV, including this treatment of this disease into a broader package is a challenge, and it is for every disease. So I think the biggest challenge is more how we strengthen the system rather than how we include SAM management. And this is where I think we lost a lot of years. We lost a lot of years in just talking about SAM, what is specific to SAM. I mean, all challenges we face with SAM, the cost and everything, it's the same that we faced with vaccination, it's the same that we faced with HIV and all the other diseases. So I really would like us to be more focused on this approach. This global challenge is the weakness of the health system today in many countries. Well.
Okay. Just a comment on what's been brought up about, having SAM and MAM within an integrated package. I agree with many of the concerns that are raised. I think, really, again, this is about proof of concept for a service delivery mechanism, but there's many, many unanswered questions about capacity, about adding MAM to the health systems and what kind of coverage you're going to be able to achieve beyond a pilot that is supported by an NGO. I did want to point out that what I think is important about the Bangladesh experience is that the addition of SAM to what at community level was an integrated package of community level services that were being delivered in terms of pneumonia treatment, diarrhea treatment, behavior change communication, infant and young child feeding practices. What we really saw there is that the cases of SAM that did come about in that context were able to be treated, where these other where SAM was not due to diarrhea, so you treat the diarrhea and the SAM is resolved. There was an extra layer available for those cases that did need it. But really, in the Bangladesh context, it's very hard in 10 minutes to kind of describe a very, large integrated 5-year program, but there was behavior change communication happening. There was quite a bit of preventive services happening, and this is really, SAM was in its proper place, just for those few children that really needed it. I also share your concerns about MAM and using products to treat MAM. I think with MAM we have options, and I think it's very easy to forget that and kind of the glamour of the product approach. So again, proof of concept, hopefully something that will be useful with SAM in countries that do have a CHW cadre that's able to implement, that's able to manage SAM. But should MAM be added? That's a question that I don't feel strongly that the answer is yes, but it could be done, I suppose, if there's interest.
Okay. Nikki, do you have some comment, especially about the mapping of MAM? With all this concern, what is happening on the ground about MAM management?
No, I'm not going to answer your question. I want to just make one plea, because I think these issues that are coming up are being replicated in the field, and there is confusion now, and maybe it's a terminology, CMAM or IMAM, and if you look at the French equivalents, there are this many. And I think if from this meeting we don't have a way forward of can we have a group or an action point of when it's appropriate to have treatment for moderate malnutrition, when is it appropriate to really focus on the integration, it'll just get replicated. So we just got asked to present what is happening out there, and I think that's my plea, that we won't solve it here, but that we actually have a plan of how, so it's not just another meeting that we in 5 years we talk about the group that want to put everything together and the group that don't. It's difficult to do everything with these programs, but that's just my plea, that we have maybe a step forward. I mean, Linda mentioned yesterday, the sort of institutionalization. When do we do moderate malnutrition? We've got UNICEF and WFP really talking. So I will throw it back to people that, there's a lot of things coming back to us, but that's the reality out there. And maybe we need to move away from some of this terminology. But the fact is we have 60 countries with CMAM or IMAM guidelines, and we have the situation that we're not working in emergencies, this is part of essential package. So there's confusion out there, and I think some expertise here. Let's try and make a way forward.
Okay. Thank you. We will still have another session. For those who didn't have a chance to ask the question, you can write it down, the question you give us. We will try to address all the remaining questions at the end of the session. Now we are moving to the presentation of Sandra Coe. She is a medical doctor with public health background also. And she's working with Epicenter, and she will talk about all her experience and specifically about some of the concerns you are addressing. Are we really selecting children who need treatment, and how can we do this to make sure that in the program there is children really who need treatment?
Yeah, it's easier like that. Good morning. I'm going to talk about MUAC as admission and or discharge criteria in nutritional programs. Since several years, there is a scale-up of community-based management of acute malnutrition. The objective of this case management can vary according to the different actors involved. There is also a wide variation in the profile of children admitted to these different programs, and also within the capacity of programs implementation in the field and the capacity to deliver programs. MUAC and Weight-48 Z-score used to diagnose children suffering from acute malnutrition are independent and imperfect indicators used to assess the nutritional status of children. They do not always identify the same children, as we can see in this diagram. In 2009, the World Health Organization recommended the combined use of Weight-48 and MUAC as admission criteria to community management of acute malnutrition programs, and percentage of weight gain as unique discharge criterion. MUAC is now increasingly used in nutritional programs as unique criterion for screening and admission of children from 6 to 59 months of age. It's an easy to use diagnostic tool that facilitates good coverage of the programs, and identifies the children at higher risk of short-term mortality and also the youngest children, as it was demonstrated in many publications. However, there remains much debate between the different actors involved in CMAM and many uncertainties regarding the strength of the existing scientific evidence to justify the use of MUAC as single criteria for admission, monitoring and/or discharge into these programs. One of the major concerns relates to the exclusion from these programs of malnourished children with a weight for weight less than -3 Z-score and a MUAC greater than 115 millimeters. To clarify these 2 points, we carry out a review of the published literature in PubMed and unpublished data from nutritional programs implemented mainly by Médecins Sans Frontières. We have collected the following indicators: proportion of children cured at discharge, length of stay, proportion of defaulters, average weight, age and MUAC gain, and risk of death in the short term. We found only 6 documents with retrospective data of programs using the MUAC as admission and/or discharge criteria. 4 published papers and 2 unpublished reports. 2 documents reported use of MUAC as admission criteria and percentage of weight gain as discharge criteria, and 4 documents address the use of MUAC as single criteria for admission and discharge. There was no comparison groups using weight for weight as admission criterion in any published or unpublished reports we have found. On program data using MUAC as admission criterion and percentage of weight gain as discharge criterion, yes. The proportion of deaths in the program were relatively low, 4%, except for a supplementary feeding program in Ethiopia. In Burkina Faso, children admitted with a smaller MUAC had a higher daily mean MUAC gain during their stay in the program. In the same program, children admitted with MUAC lower than 100 millimeter had a mean weight for weight smaller than -2 Z-score as discharge, and an average MUAC less than 120 millimeter. The average length of stay was also higher for children less malnourished on admission. On this table, you can see that the average length of stay was around 45 days for children admitted with a MUAC less than 100 millimeters, against 56 days for children admitted with a MUAC between 116 and 118 millimeters. On program data using MUAC as single criteria for admission and for discharge, the most severely malnourished at admission had the longest length of stay in the program. In Burkina and India, mean MUAC and mean weight daily gain were parallel during the stay in the program, and children with lower MUAC at admission and as a higher mean daily weight gain and higher mean daily MUAC gain. All children had a weight for weight greater than -2 Z-score as discharge in these 2 programs. The proportion of defaulters were very important in Guinea-Bissau and Indian programs, over 30%, while it was less than 120 in the MSF program in Burkina Faso and North Sudan. In unpublished reports compared 2 groups of children admitted between 2010 and 2011 in an MSF program in Awil, South Sudan, with the following admission criteria: weight for weight less than -3 Z-score and or MUAC less than 150 millimeters. The group of children admitted with a MUAC less than 115 millimeters, regardless of their weight for weight, was compared to the children admitted with weight for weight less than -3 and a MUAC greater than 115 millimeters. This table shows a lower proportion of cured children and a higher proportion of defaulters in the group of children admitted with a MUAC less than 115 millimeters. The proportion of defaulters were above 15% in both groups. The mean weight daily gain and the mean MUAC daily gain were higher in the group of children admitted with a MUAC less than 115 millimeters. The average length of stay were similar in both groups. Finally, 31% of deaths in the program occur in the group of children admitted with a MUAC over 115, against only 2% in the group of children admitted with a weight for age greater than -3 Z-score. Regarding the evolution of children with a weight for 8 less than -3 Z-score and a MUAC over 115 millimeters at admission, a recently published study shows a follow-up of a sample of children in the slum of Dhaka in Bangladesh again. 158 children were with a weight for 8 less than -3 and a MUAC greater than 115 at admission were recruited from a primary health care without any nutritional programs and follow up for 3 months with 2 weekly visits to assess their anthropometric evolution and the occurrence of deaths during this period. Among the 158 children follow-up, 21 were lost to follow-up. Of the remaining 137 children, 7% had to be admitted to a nutrition program for having a MUAC under 150 millimeters, a loss of weight equal or greater than 10% of the occurrence of severe medical condition. Finally, among the remaining 128 children who completed the follow-up 3 months, 66% improved their nutritional status and 27 maintained their weight for 8 under -3. In total, 93% of children improve or maintain their nutritional status after 3 months of follow-up. So in total, the authors draw the following conclusion from the available data. Children diagnosed as acutely malnourished on low MUAC responded adequately to the nutritional programs. Children admitted to the program with lower MUAC had a greater mean MUAC daily gain during their stay in the programs. It seems acceptable to use MUAC as a single criteria for admission, according to the available data of follow-up of children admitted with a weight for 8 less than -3 and a MUAC greater than 115. The use of percentage of weight gain as discharge criteria for program admitting children on MUAC only led to a shorter length of stay for the most malnourished children at admission, and these children were being discharged when still moderately malnourished compared to the other group. The use of MUAC as discharge criterion gave more consistent results in MAM programs using MUAC as single criteria for admission. So, at the end of 2013, the WHO Nutrition Expert Advisory Group published a new guideline, a new manual. And in this manual, we can find that percentage of weight gain should no longer be used as discharge criteria in CMAM programs, and that children admitted under one criterion should be discharged under the same criterion, either weight for 8 or MUAC. MUAC as single criteria for admission and discharge should allow to identify the children at higher risk of death, to improve the outcomes for most malnourished children, and to obtain a higher level of coverage of CMAM programs. It could lead also to an increase in absolute cost of programs, as we have discussed, owing to the increased number of children being identified, but no change in cost effectiveness at the end, and potential saving could be made with earlier detection and reduced number of children being admitted later on complicated severe acute malnutrition. Many programs in lower resource settings are already implementing this approach, but the new WHO recommendations are not yet widespread. Further data needs to be collected, of course, and analyzed. For example, the use of 125 mm as MUAC cutoff at discharge needs to be validated and verified. Is it high enough to avoid the risk of relapse? This is one of the questions. If CMIM programs use MUAC at admission and discharge criteria, could we use MUAC for treatment monitoring during the stay in the program and forget about weight? This is another question. And if we consider some data presented here from Burkina in India, we can say that we can use MUAC as monitoring, but it should be confined. Thank you for your attention.
Thank you very much, Sandra. So we'll move to the last presentation of this morning session. It will be by Mark Manry. I don't know if I need to present him in this audience. And if almost all the people know him, and when we met last time in London, people were asking how many of Mark Manary we have in the nutritional world, because it seems that he was having a lot of presentation in this meeting, so we'll have to know him much better maybe in other presentation. We have to catch on time. Mark Manry is going to talk about the long-term outcome of children who have been through a treatment of MAM. The floor is yours, Mark.
Thank you, Paluku. I want to focus the next few minutes on just a couple of simple messages from studies that we did in Malawi. And so to first of all say this is only about kids with MAM, and my context is rural sub-Saharan Africa, places where people live in mud huts with grass roofs, and they grow a lot of their food themselves. They cook it outside over wood, and so that that obviously represents lots of people in some sense. It may not represent everybody everywhere in the world, but this particular line that I know probably everyone in this room resonates with is that, we've got many millions of kids in this world with MAM, and they are at a fourfold risk of death, and they have more chance of getting diarrhea and pneumonia, and we need to do something about that, and that's why we need to do supplementary feeding. We need to reduce this risk of something very serious happening. And then we go on into a variety of different supplementary feeding programs. So what prompted this question was the fact that we looked carefully, we thought, in the literature, and we couldn't find follow-up studies of people given successful supplementary feeding. We couldn't find that, yes, this reduced their risk, or even, what their nutritional status was a year later. And so we're not talking about something that requires a lot of technology. We're just talking about an observational study. And that's what we embarked upon, and I'll share with you some data here first about. So these were kids who were fed in a randomized controlled clinical trial for comparing 3 different food groups. It was the first study with Super Cereal Plus. And they had great recovery rates. They had about a 90% recovery. And then we went on just to follow these kids over the next year without any kinds of interventions. In terms of their initial treatment, they did have, drama groups and talks and encouragement from nurses about good nutrition. But there was no distribution of food products after their treatment from MAM was done. Fairly conventional program where, was a weight for height Z program where you qualified by being between -2 and -3, and you graduated when you were over -2. So, looking here at struggling a little bit with the audiovisual stuff, but I'm supposed to use this stuff here, okay. So these 3 foods were, one was Super Cereal Plus, and there were 2 ready RUSF products, one with milk protein and one without. We categorized everybody at these intervals very simply in just one of 5 groups. We said you were well-nourished, which means you either had a MUAC over 12.5 or over, or you had a weight for height Z-score greater than -2. So we weren't trying to be very stringent and sort of find something wrong with every one of these kids and say, see, the program never works at all. But we tried to make it so that if you had by either of these criteria were described as well-nourished, then you were counted as well-nourished. Relapse, and consequently, was having both low MUAC and weight for height Z-score. Several children developed SAM. This is something that we've noticed even in our midst of our treatment programs, that 5% of kids develop SAM. It's something that may not apply to every context, because this kind of SAM that these children develop is usually edema. But that's the third outcome. Loss to follow-up and then death. Okay? And this here is the crux of the information. So we had about 2,000 kids, and what we see is that in the first, these boxes here represent what happens in the first 3 months, these ones in the first 6 months, or in between 3 and 6 months, and these ones between 6 and 12 months. So that about 1.3 or so % of these kids died in the first 3 months, and about 80% or so remained well nourished. And we wondered too if this risk all concentrated right on the front end of their recovery from MAM. Is it because their body is anthropometrically recovered and maybe their immune system hasn't recovered or something like that. But no, we see that the increased risk of death and relapse and developing SAM just continues on out for a year. There's a very seasonal pattern to it. I didn't include that picture, but in Malawi we've got a one harvest and we've got a very seasonal food shortage. And so a lot of these cases become concentrated in that season. And this slide shows you some of the same information. So these kids, 80% were well nourished at 3 months, 70% at 6 months, and 62% at 1 year. And 4% of these kids died, which is about fourfold what we would expect in this population. So we would expect about a 1% death rate among just the typical rural Malawian kids. When I looked at these kind of things, I felt disappointed, because I expected that this would be 95%. When we've looked at this with SAM kids, we've gotten pretty good rates. We've gotten over 90% when we go back to find these kids a year are not anthropometrically malnourished. And we did compare the different foods. There's what I would say, to downplay it a bit, a nominal but statistically significant difference in the relapse among children who received what some may say are the best food, which is a paste with whey in it, versus an intermediate value for the flour. But I really don't think that's the heart of the issue, that a food product would particularly make the difference here. Some regression analysis to say what was the risk factors for good outcome. Your mother's alive and she's taking care of you, you don't have HIV infection, and you're recovered with a higher anthropometry. And risk factors for death are also not very surprising, but they point to what things we may need to do in our programs. Stunting is a risk factor for death, your father having died, and a lower MUAC. And then briefly now, I just want to tell you about a subgroup that we also did in that same study from the follow-up. We took about 400 kids and we said, let's feed them for 12 weeks. Let's just feed them for a whole 12 weeks, no matter what their anthropometry is. And naturally, the mean recovery time in the first group we talked about was 3 weeks. So, this is going to be a significant more amount of food, and see what happens with those kids. And what happens is that this was 382 kids who were in the same population, the same of those as the group before, from the same study, the same time, subject to the same seasons and variations and socioeconomic conditions there in Malawi. Well, 83%, which remained well nourished at 3 months, and 80% or so at 6 months, and about 73% at a year. So those are different numbers to a statistician. And so you can get a little bit of benefit by feeding these children for a longer period of time. There's still something we're missing. The heart of the issue is still that there's lots of these kids are not doing fine at a year. The death rate was only 1%. And this is a chart to tell you those are many statistically significant differences if you feed for 12 weeks versus feed to goal. So this is just the question I want to put forth, and that we're also putting forth in terms of some research that we're doing now, is so what could help these kids? If it feels to me like this, like maybe a different food product would help some. Maybe feeding longer would help some. They're still looking at a pretty, of that third of kids who we would say fail at a year, still most of those aren't going to be helped by that particular type of intervention. Would micronutrient supplementation that went on after this help? Would addressing the most common infectious disease they would have during the rainy season, malaria, would that help? Would educational interventions help? Or, I don't know, I don't never do it, but would it be cash transfer help or something like this? So that's what I have to say, is that I don't know of data from other places, but we should also be looking at what's happening to those kids who were successfully treated with MAM, and think about what we might need to do to keep that success up.
Thank you, Mark. Just to start, I don't know if the presentation has answered the concern of people asking themselves if we should be treating children with MAM or no. For myself, I can say that it has answered that these children are also children at risk. Maybe it depends where we put the cutoff and saying those who have to be treated. Maybe it depends with the criteria, but we cannot just say that all the children with MAM don't need treatment. That's what I get from these two presentations. I don't know if that the question now, the floor is for the audience to ask questions about the two presentations. Okay. Sorry.
Thank you very much. My name is Bridget Idam from World Vision International. My questions are for Sandra and Mark. The first question is, Sandra, I know we've done some surveys that show that MAC tends to underestimate. Actually, when you're using MAC compared to weight for height, you can tend to underestimate global acute malnutrition if you use weight for height in some populations. But I've heard the other argument also, that in other populations, it's overestimated. So in your experience in elite review, did you come across any of such comparisons, and what is your take on that? And then for Mark, the follow-up of the children with 4% dying in some cases, when you saw a deterioration, did you check for deterioration in the children? When you saw that, was there any attempt made to kind of intervene or send them to health centers or so to prevent death, or were they allowed to just die? Just a quick question.
Good morning, Frank Wieringa from IRD France. Sandra, thank you very much for a very interesting presentation on the issue of MUAC versus weight for height. What worries me is that we are somehow stuck to one cutoff for MUAC. We're all thinking that we have to use the same cutoff value for starting treatment and for screening. Whereas, why can we not have several cutoffs? For the community, we have a higher cutoff for MUAC, and we say, well, these children are perhaps at risk for having either a MUAC less than 11.5, so we should start treatment, or they're at a high risk for a low weight to height Z-score. So we need to follow up these kids. And then we can start treatment when either the MUAC is low or the weight to height Z-score is low. And when we start treatment on one criteria, we continue to follow that criteria. We tend to say, well, we only should use MUAC or we should only use weight for height, whereas I think we all agree that they are measuring different things, but they identify children who are at risk for death. And I think that is the most important. We need to identify which child should receive treatment, whether his MUAC is low or his weight for height is low. So the bottom point is, can we move away from one cutoff for MUAC with the same cutoff for screening and for treatment, but move somewhere that we use MUAC as two different indicators, one for screening and one to start treatment.
Ellen next. Ellen Mulhoff.
Okay, thank you very much. Ellen Mulhoff from FAO. I would like to comment on Mark Mannery's study. Thank you very much. That was extremely interesting. And I think it's one of the few studies that has actually looked at what happens after children are discharged from feeding programs. I think we need a lot more of that type of data, actually. I think it clearly shows that there is a need really for follow-up and for better integration of treatment and prevention, for which I would like to argue. I've been listening to the very interesting presentations this morning. And, like I said in my 5 minutes yesterday, I think we need to put a much, much higher emphasis on prevention. I think in Malawi it's perhaps not surprising to see that not all children did well after they were discharged, because when you look at the local diet and you see what children are normally being fed, it is a very monotonous, very inadequate kind of diet, especially when it comes to complementary feeding, composed mainly of maize flour, a little water, and sugar or salt. And when children get a little older, perhaps a few vegetables are added. Meat is hardly in the diet, no animal source foods, fruits are hardly fed, etc. And it does not necessarily mean that these foods are not available or not accessible. There are certainly seasonal differences, there's poverty, there's food insecurity, but I think all these issues need to be addressed. And I do also think that nutrition education is key. FAO is currently working in Malawi in 2 districts, in Kasungu and Zimba, where we are conducting intensive nutrition education through the government system. We are using government extension workers from health and from agriculture to promote intensive nutrition education in the context of a household food security program which is directed at dietary diversification. And we are seeing that actually quite significant improvements in children's diets are possible. I'm not saying that we can fill the entire nutrient gap, but significant improvements are possible. And I think this is where we need to do a lot more. We are also following this work through collaboration with Bunda College and my colleague here, Irmgard Jordan from Gießen University in Germany. We are conducting clinically controlled trials, randomly controlled trials, whereby we have a control and an intervention group. The controlled children only receive food security, the parents are getting food security inputs, and the intervention group gets food security and nutrition education, and we are following up these families over a period of 2 or 3 years to see what the outcomes are.
Ellen, I'm going to cut you off.
I would like to make it sure. I know I would have really loved to have an opportunity to talk about this more. But in any case, I do think I would really like to make a point in favor of linking prevention and treatment much more effectively. I think this is where we are missing out, and there is a big gap in terms of programming.
Okay, thank you.
Carlos.
Yeah, my name is Carlos Grijalva. I'm from University College London. My question is to Sandra. One of the things that we know is that MUAC is very strongly, and I stress the word strongly, kind of affected by things like height, age, sex. So I was quite struck by your ranking of different MUAC values. And I wanted to ask you, what's the technical basis for categorizing those brackets of MUAC values as more severely malnourished, as opposed to say these are just shorter children, or these are more girls, there's more girl proportion as we're going down the line, or these are just younger children. Why are we categorizing or making a connection that lower MUAC values means more severely malnourished? And the second one is, based on the same premises, did you assess the effect of age or height in the assessment that you did on your values? Did the findings that you found were similar among taller children or younger children versus older children, or boys and girls? Thank you.
Yes, Sandra.
Okay.
with the first question. So, if I understood well, you address the fact that in some population we can use one diagnostic tools, and in other population we can use different tools. Let me to come back on my presentation. It's true that the indicators, the weight for height and the MUAC are both imperfect indicators and both independent indicators. They are not identified the same children in the population. So this is the first thing. And WHO recommends to use one or the two of these indicators as admission criteria in the program. So it's true that you can adapt the admission criteria you want depending of the population, and it's exactly the same also point for the cutoff. The second question was about the cutoff of the MUAC to admit children in the program. But my point was mainly to emphasize the fact that first, when you use MUAC, we are talking about CMAM programs, mainly CMAM programs, so community-based programs. And when you use MUAC, it's easy to use, and of course it's easy to increase your coverage like that, because you can have more children in your programs like that. So it's a very interesting tool for that. And also, I would like to emphasize the fact that WHO gives still the capacity to use one of the two criteria as admission criteria, but the important point in this new manual is that if you use one criteria for admission, you should keep the same criteria and use it for the discharge criteria. And we should forget the percentage of weight gain, because we have shown that there is enough evidence to say that it's no more relevant. So the key point is to use the same criteria for admission and discharge. And one of the other interesting things is to see if we can use also MUAC for monitoring children inside the programs, and forget about weight to monitor them. In the data we had, it seems that the gain of MUAC is parallel to the weight gain in the program, so we can maybe use the same tools from the beginning at admission to the end at discharge, and for monitoring. This is one of the key points. And of course the cutoff MUAC, it's an interesting discussion about capacity to deliver programs, and we are back to the discussion we had before, I think. And if you choose 120 or 120 as an inclusion criteria, of course you will have much more children to deal with. And it's also linked with the question of Mike about the fact that should we treat the MAM children exactly as the SAM children. Okay, so this was the first and the second criteria, the second question. And the last question, we say that when you have, we just focus on the WHO recommendation, MUAC less than 100 millimeters correspond to children more severely malnourished than the MUAC around 110 or 115. It's cutoff that has been decided, that had been adopted by WHO, and that's why we try to compare the degree of malnutrition according to this cutoff. It's exactly the same thing with the weight for height, -3 or -2 that score. It's different kind of level of severity of malnutrition. And I just wanted also to tell you that I did not do myself the calculation, because it was a literature review, as you noticed. But regarding the age and what was the sex, there were no consideration about the sex in the analysis, I think, but age was taken into consideration. Height question. Height is related to weight for height, but not for MUAC. No, not height for MUAC. But it was children from 6 to 59 months of age, and we know that MUAC identified the youngest children. I hope I give an answer to your question.
Mark, do you want to take the question about whether you just sat back and watched the children die?
Yeah. So our clinics are operating at these sites every 2 weeks, and we had a fairly high level of healthcare provider at the clinic, so either a very senior nurse, sometimes even a physician. And mothers were always encouraged that they could always come back to clinic whenever we were there, just to be measured. So when I say something happened at 3 months, it really happened over the first 3 months. We weren't there 24 hours 7, and we didn't have a big supply of medicines or something. We did provide transport to the hospital or the health center if needed. And so I would even say that this is probably at a level that is a little better than the health surveillance assistant, the village health aide sort of care that those folks get access to, but comparable to what real life people get. So it wasn't. It wouldn't be really that interesting, to report no deaths, but we had a emergency rescue team there waiting for them all the time or something like that. So I do believe that those children are at more higher risk of death.
Andor or Chloe, do you have anything to add? Nikki? Okay, open floor, lady right at the back, lady right at the front, and gentleman over there.
Thank you. Hi, my name's Hattie Barthorpe from Goal. And I wanted to, I don't think the question has yet actually been answered on height, but does not stunting have the potential to skew our interpretation of malnutrition prevalence using MUAC in the same way that weight for height is affected by low Cormick index? So in South Sudan, for example, the FANTA-2 analysis showed that MAM weight for height Z scores had 5 to 10 times higher prevalence of malnutrition than MUAC did, and SAM was 3 to 13 times higher. But in populations with very, very high stunting, so we've got an example from Sudan in Kassala, in Hamish Kareb, whereby our weight for height Z score, GAM, was 15%, but the MUAC showed the GAM as 27%. So are these children actually malnourished, or is the anthropometry using MUAC actually overestimating the percentage in very highly stunted populations, as weight for height does in communities with a low Cormick index?
Can I just remind you to introduce yourselves when you pose a question, please?
I did.
Yeah, hello. I'm Hanan El Hadi. Actually, I'm coming direct from Sudan, but I study in Germany, my PhD in Gießen University in project and regional planning. Actually, my question is very general for the people today or yesterday, for everyone here, because I present a poster about the moringa, about the baby supplement nutrition, and I hear a lot about the moringa for combating and preventing the malnutrition. And these three, everyone, every woman, every poor people in Sudan, I mean in Africa, Latin America, and even in Asia, because this tree is originally from Asia, can grow it here. And my question is, do you hear about it, try it, or maybe make the analysis? I don't know, but what I'm hearing and what I'm reading and what I found, this tree is very crazy to combat this malnutrition, because it is very enhanced in all the nutrition needed for the children and for the pregnant women.
Was there a third question at the back? Gentlemen? No. We'll have you, sir, at the back.
Thank you so much. My name is Sylvester Gatumba from Malawi. I just wanted to provide a warning shot on Sandra presentation. Firstly, I needed to agree that MUAC is a very important approach in assessment as well as monitoring. But I would like to disagree that it's an easy approach. Most of us, I think, when you consider MOAC, when you look at the procedure, we consider it as an easy approach to take. But I think observation has shown that it is difficult, especially in terms of service delivery. When you are doing studies, short studies, normally we take the best people to do the assessment. But for the community health workers, when they have a lot of children, to follow the procedures of MOAC assessment, it has shown that it is one of the difficult approaches. So I think when we are taking this approach as a tool to assess and monitor the children, I think we need to constantly monitor the service providers. Otherwise, we'll be making wrong decisions and having wrong people in the program. I think it needs constant monitoring in the first place when we are implementing this particular approach. Thank you so much.
Okay, do you want to take those three questions? And if we've got time, we'll have another round. Sandra, maybe you can start again. Or Mark. Mark, you go.
We have used moringa in some test batches with therapeutic foods, and not really encouraged sort of wholesale wide community use of it. And we haven't found it to be particularly powerful or magical. I mean, there's nothing necessarily harmful about it. It has a lot of antioxidants in it. But I'd say experience is limited.
I'd just like to add on the moringa comment. I think, there's many different interesting options to explore. Interesting to hear Mark's experience with moringa. But in terms of what works for MAM, I just think, perhaps there is no silver bullet, and we really need to explore in different contexts what's acceptable, what works. There may be many options. We need to, I think some of the discussions we've had today have really highlighted the importance of counseling, FAO's work with local foods, possible supplements where needed. Especially with MAM, I get a bit nervous when we start thinking in silver bullet type approaches, whether it's, a particular plant or a particular product.
Thank you. Regarding my question, I'm not sure it was really a question, but much more opinion about MUAC and the use of MUAC. Regarding I think the first one was a question about the effect of the hate. It was a little bit the same thing than you on the MUAC. And MUAC between 6 months and 59 months is not independent from age, but for me, in my knowledge, it's independent for age. So maybe there are some publication or research going on this, but I'm happy to discuss it after if you want. And second question, I take your point, and I'm sure it's related to your experience and the way you experience the use of MUAC in your programs. But in my experience, MUAC is, and I train community health workers to use MUAC a lot, and in my experience, MUAC it's really easy to use, and community health workers like these tools, and it's not easy to train community health workers to use it. And I really do believe that it's easier than using a weight and age for inclusion criteria and for screening criteria inside the population, and especially in some difficult context and in emergency. So it's two different kind of experiences.
Yeah, perhaps I will go back to what Chloe said, and I think going back also to the presentation we had and what was said by the lady of FAO, I think there is a set of intervention that can be proposed. Some have to be delivered by the health system and are already known as essential nutrition action or specific nutrition action. and they are supposed to be delivered already in all countries as gross monitoring, anti and postnatal care, all the IYCF package that has to be delivered through the health professionals, and making sure that we as a community don't forget to have this continuum of care proposed to mothers and children, and that you have true access to that, I think would be a good start, rather than looking at pieces of a response. And then we have to link with the food-based approach and more the food system and environment, and linking with, as yesterday Rebecca said, WASH interventions, food security and livelihoods interventions, of course, in order to make the prevention approach more complete. But we have already stuff that should be delivered. People have the right to have access to these. And really, I think we should make sure that we don't give or support only pieces of this broader picture.
Okay, Andre, one last point. Very quick.
I want to come back to this issue of MUAC. I'm afraid the discussion is a little bit repetitive meeting after meeting. MUAC is a good indicator to assess the risk of death. MUAC does increase with age, and it is correlated with height. Taller children have a bigger MUAC. But in terms of risk assessment, assessing the risk of death, you don't gain anything in correcting for age or for height. So MUAC surveys are not good surveys to assess nutritional status of a population, but in settings where MUAC is used as criteria admission, you need MUAC surveys to estimate caseload, potential caseload. I think we can avoid this confusion if we make clear that MUAC is an indicator of risk of death of children needing treatment, and we should forget about this correspondence with other indicators.
Mike.
Thank you.
Quickly,
Sandra,
please.
the South Sudan Awil study which you presented is a very particular population of Nua and Dinka, and we cannot really extrapolate those data to other populations which have completely different body shape and so on. Now, if I saw your data correctly, there were 42 deaths and 30 were identified by the MUAC less than 115, which means that the 12 other deaths, in other words, 1/3 of the deaths of your children occurred in children who would not have been admitted if it was a MUAC-only program. You can confirm or not that from the data. I was just looking at it flashing in front of me.
Sorry, Mike, I'm going to stop you. Can I suggest that you have that during coffee? It's very specific, and we're out of time. I thought you wanted to make a point of clarification.
Yeah, I wanted to ask Mark something, please. Paluku said, do we give them supplement or we give them no treatment? Nobody is suggesting that a MAM child should get no treatment. I think I really want to emphasize, Paluku, that was not what we meant. But we should not be giving them supplements. And I want to ask Mark whether he thinks if we improve the economy of the household with a livelihood approach, whether that would have had a sustained effect over the 12 months of your follow-up. And as a corollary to that, why aren't we also doing livelihood support to the SAM children? And not only giving the SAM plumping up, but I think the MAM children should be getting a livelihood approach, but the SAM children should also be getting livelihood approach. And in other words, we should not be taking the SAM treatment and applying it to MAM, but we should be taking the MAM treatment, the developmental MAM treatment, and applying it in addition to SAM.
Okay. I think that has been a very, very good session with a lot of interesting discussion, going from what should be the component of a real CMAM program. From the start, actually, the CMAM program was conceived as something that we should include both the treatment of SAM, the treatment of MAM, and prevention activities, including integration with other activity going on in the community in terms of prevention, strengthening the food security of the household and the community. What I understood from all this discussion is that from the start, from the planning stage, to the time you start implementing SAM, and even after the children have been discharged from the program, we still have to keep that in mind, that you don't have to go and do things in isolation, not only concentrating on treatment of SAM, but have it as a continuum of care, starting from prevention, activity for children of the household that unfortunately they have a child with malnutrition, going to the treatment and following up with activity or support that can make sure that these children don't relapse or don't die after the child. And in Dominique's presentation, he did really emphasize the fact that when a child is malnourished, that means that it's only that condition that he's had. And when a child is malnourished, it doesn't have to be treated in a separate place. We have to consider that this is a disease that has to be integrated during delivery, in planning, in trying to strengthen the health service with all the other conditions that children are affecting children in our developing country. And there has been a lot of concern and discussion about should we use same protocol for MAM and some children. I think the consensus is that we need to make sure that we tailor the treatment to the need of the child in terms of criteria, in terms of protocol, in terms of what we do for these children. It has to depend with their need and the risk they face about death. Just on word on my own experience to come back to these children with MAM, do they need treatment or not? My experience when I was still working in a hospital with these children, even the MAM, you don't have to consider MAM as isolation. MAM, when these children come with MAM and the malaria, they have at higher risk of dying than children who come with good nutrition status than when they come with pneumonia and moderate malnutrition, they are higher risk of dying than children who are well nourished. So I think definitely treatment of MAM is just not a nutritional treatment. It's also a prevention for dying from other disease. It's also prevention for deteriorating to SAM. Sometimes we all agree that when you deteriorate to SAM, even when you recover, we don't know if the risk after the treatment is still not increased in terms of risk of death. There was a lot of concern about caseload when you include MAM in this approach of treatment, you increase the caseload. But Chloe case study showed that at least when the program is decentralized, it's at community level, the workload was not much increased and it was still manageable by this community. Probably it's a different situation when you are in an emergency context with food crisis. You can have a lot of children of MAM coming, but when you are in different context, sometimes we can see that the caseload will not be really much increased. So in going together with this issue of caseload was the big issue about government capacity of coping of the cost of including MAM treatment in our nutrition programming. That question comes always when nutritionists meet. It doesn't come when HIV people working in the HIV program are meeting. Them, I think they managed to organize themselves to have a good advocacy teams. When I was still working as pediatrician, I was in HIV ward. When ARV came in, everyone said this is not treatment for developing country, it's too expensive. But today they are pushing the cutoff, increasing the cost of HIV treatment worldwide without them being concerned about the capacity of government coping. When we talk about government, I think you talk about government and the partners. Government and the partners, and when we say that nutrition has to be a priority, we need to also build a team of good advocates for making sure that resources are dedicated to nutrition. We don't have to limit ourselves based on the fact that to be pessimistic, as Tamid said, let us be optimistic and say, okay, we will go there to look where funds are, to make sure that all children with malnutrition and the risk of dying are treated in integrated program which combine prevention, food security intervention, all other activity, and give the right treatment to the child who are severely malnourished, and appropriate treatment depending on their risk to the children with moderate acute malnutrition. Still, it is correct that maybe we still need to work on cutoff, to try to refine a cutoff in terms of screening, cutoff in terms of when to start the treatment, and cutoff in terms of when to discharge children from SAM to MAM. But I think the take-home message for me will be that we need to make sure that we integrate our program, we give a combined different type of intervention, and we make sure that all the children who need treatment, they get the treatment they need. Thank you very much. Time is for lunch.